Hello, in today's presentation we will be discussing the paper called Biomarkers for Response in Major Depression, comparing paroxetine and venlafaxine from two randomized placebo-controlled clinical studies by Lucia Carboni and others. Major depressive disorder is the fourth leading cause of disability worldwide. It is typically diagnosed using a list of symptoms known as the DSM-5, which is shown in the figure on the left. In order to have a major depressive disorder, 5 or more of the symptoms on this list must have occurred within the same 2-week period. This makes diagnosing major depressive disorder difficult as the pathophysiology for this disease is unknown. Recent studies have been trying to identify a biomarker that indicates whether a patient could have major depressive disorder. The existence of such a biomarker would be a significant finding as it would influence patient diagnosis, shifting from a symptom-based approach of diagnosis to a laboratory test. Additionally, treatment would be affected as new drug therapies could be made. The hypothesis that this paper uses to identify biomarkers of major depressive disorder is the immunoinflammatory hypothesis. This hypothesis suggests that inflammatory stimuli can elicit depressive-like symptoms. Therefore, biomarkers leading to increased inflammation are thought to contribute to the symptoms of major depressive disorder, as outlined in the figure to the right. Previous studies have shown early confirmation of this hypothesis. After therapeutic use of IL-2 or INF-alpha, both being pro-inflammatory factors, major depressive symptoms were induced. In other studies, it was documented that cytokines, chemokines, and other inflammatory markers were seen in depressed patients. Although there is still conflict within the literature, a meta-analysis did not reveal any statistically significant increase in depressive symptoms between cytokine levels in treatment responders and non-responders. Additionally, researchers are still trying to identify a link between the immune and nervous systems. The inflammation biomarkers that we will be discussing from this study are interleukin-6, tumor necrosis factor alpha, tumor necrosis factor 2, interleukin-10, C-reactive protein, and matrix metalloproteinase 9. Interleukin-6 is a pro-inflammatory cytokine that induces proteins in acute inflammation. Tumor necrosis factor alpha is another inflammatory cytokine produced by macrophages or monocytes, which are responsible for signaling within cells for necrosis or apoptosis. Tumor necrosis factor 2 is another inflammatory cytokine that induces inflammation and apoptosis. Interleukin-10 is another inflammatory cytokine. C-reactive protein is secreted by the liver in response to inflammation, and it is used to monitor inflammatory states. Matrix metalloproteinase 9 regulates pathological remodeling processes that involve inflammation. The main research questions of this study was, firstly, what is the association between pre-treatment biomarker levels and major depressive disorder severity? The aim of this is to identify markers for depression. The second question is, what is the association between changes in blood biomarkers and changes in depressive symptomatology? The aim of this question is to identify markers for treatment efficacy. And lastly, the third question is, what is the association between baseline biomarker profile and changes in efficacy endpoint? The aim of this question is to identify biomarkers that can predict treatment response to antidepressants.
Moving on to methods and materials, the biomarkers that were chosen all belong to immunoinflammatory pathways. This is because there has been a lot of evidence showing that peripheral immune activation plays a role in the pathophysiology of major depressive disorder. Therefore, we use these biomarkers in order to predict the treatment response in major depressive disorder to find the best antidepressant. A total of 2 10-week independent, randomized, placebo and active-controlled, flexible dose studies in male and female outpatients were carried out. So the first study is called the paroxetine study, and paroxetine is a selective serotonin reuptake inhibitor, an SSRI. and the second study was called the venlafaxine study, which is a selective norepinephrine reuptake inhibitor, the SNRI. For both studies, paroxetine and venlafaxine was compared to a triple reuptake inhibitor, the TRI, and to a control, the placebo. So in the paroxetine study, 171 subjects were given the TRI, 166 was given paroxetine, and 156 was given the placebo. A total of 70% of the subjects completed the trial. In the venlafaxine study, 134 were given the TRI, 133 was given venlafaxine, and 126 was given the placebo. A total of 59% completed the trial. So moving on to assess treatment efficacy. Treatment efficacy for both studies were evaluated using the Inventory of Depressive Symptomatology, the IDS, which is a 17-item version of the Hamilton Rating Scale for Depression, HMD. The 6-item Beck subscale was also used, and this is derived also from the HMD. Additionally, for the paroxetine study only, the Montgomery-Asberg Depression Rating Scale was used to assess treatment efficacy. Moving on to biomarker analysis. Analysis was restricted to only paroxetine, venlafaxine, and a placebo. This is because the TRI showed no efficacy. Blood samples were collected at random at week 0 and week 10. Some a priori criteria were also applied. Blood samples were submitted to biomarker analysis only for patients of Caucasian origin, patients completing the week 10 assessment, patients not coded as protocol violators, and patients from centers where at least 10 patients have completed the study. These criteria were applied to minimize heterogeneity in biomarkers data, which might be sensitive to ethnicity and country-specific effects, as well as treatment compliance, thus increasing the chance of detecting biomarker response associations. Statistical analysis was also conducted to explore the distribution of each biomarker. All the biomarkers were log transformed to achieve normality. A bivariate mixed model analysis was also conducted to assess the correlation between HMD and each biomarker at week 10. Also included was the change in biomarker and change in HMD as dependent variables. It was adjusted for gender, biomarker baseline, and HMD baseline. Additional statistical analysis were carried out in order to assess the potential of biomarker baseline values as a predictor. Audit testing was done at a nominal significance level of 0.05.
So, moving forward to the results. The researchers recruited more females than males to a ratio of approximately 60-40. The researchers looked at efficacy to determine which group should be included in further analyses. Both the SSRI groups and the SNRI groups had significant reductions in symptoms compared to placebo, as measured on the Hamilton Depression Scale, while the triple reuptake inhibitor groups from each study did not differ from placebo. As such, the triple reuptake inhibitor groups were not included in subsequent analyses. When looking at the correlations between biomarkers and baseline depression severity for the paroxetine group, the researchers found a positive correlation between interleukin-6 and interleukin-10 in the severity of depression, such that high IL-6 and IL-10 levels were associated with more severe depression. They found a negative correlation between tissue necrosis factor 2 and the severity of depression, such that high TNFR2 levels were associated with less severe depression. The researchers then looked at sex-specific characteristics and found that these correlations were significant across the whole sample and in males, but were not significant when isolating female participants. Analysis of the venlafaxine group revealed a positive correlation between brain-derived neurotrophic factor and the severity of depression, such that increased BDNF levels at baseline were related to increased depression severity. However, this finding was only significant in females when analyzing the sexes independently. Next, the researchers looked for correlations between changes in biomarker concentrations and changes in symptom severity, or clinical changes. For the paroxetine group, they found that increases in IL-6, IL-10, tissue necrosis factor alpha, and C-reactive protein
negatively correlated with depression scores across the sample population, such that increases in these markers corresponded to decreased symptom severity. This is shown on the graphs on the right for IL-6 on the top and IL-10 on the bottom. Both graphs depict percent Hamilton Depression Score changes on the x-axis and log 10 shifts of the biomarker concentrations on the y-axis. We can see that increases in both IL-6 and IL-10 correspond with improved HAM-D scores. When splitting for the sexes, the correlation between the clinical changes in CRP persisted in both males and females, while the correlation for IL-10 persisted only in males. In the venlafaxine study, changes in biomarkers did not correlate with clinical changes. Finally, the researchers used modeling to predict the treatment response from participants' baseline biomarker profiles. They found that high TNF-alpha and high IL-10 levels at baseline predicted a better treatment response to paroxetine. Further, IL-10 was found to be the best predictor of treatment response, with participants who had higher IL-10 at baseline being more likely to be considered treatment responders. Treatment responders were characterized as those who experienced a 50% or greater reduction in severity on the Hamilton Depression Scale. These results persisted in both males and females when separating by sex. Lastly, they found that high CRP values at baseline predicted a slightly better response to the venlafaxine treatment in males only. While this relationship was statistically significant, it was not clinically significant and therefore was not greatly emphasized by the researchers.
Major conclusions. Some of the major conclusions of this study include the following. Firstly, there was a significant association between depression scores and levels of interleukin-6, tumor necrosis factor alpha, tumor necrosis factor receptor 2, interleukin-10, C-reactive protein, brain-derived neurotrophic factor, plasminogen activator inhibitor 1 active, and matrix metalloproteinase 9. Secondly, increased baseline levels of IL-10, IL-6, TNF-A in major depressive disorder patients may be associated with a better response to paroxetine treatment. Lastly, immune dysregulation in depressive disorders involves both pro-inflammatory and anti-inflammatory cytokines. This information could eventually be used to match appropriate pharmacotherapy to given patients based on their baseline biomarkers. This would result in faster, more effective treatments for MDD. Also, it is worth mentioning that different patterns of immune system activation during depression and antidepressant treatment was found in male and female patients. To elaborate on these findings, for the first major conclusion, high IL-6 and IL-10 at baseline correlated with high baseline depression scores, meaning it's elevated in those with more severe depression. Increases in TNF-alpha, IL-6, IL-10, and CRP was correlated with a reduction in depression symptoms, meaning low depression scores. But this finding was not consistent across studies and sexes. For the second conclusion, baseline IL-10 levels can identify patient subgroups that are likely to be responders to paroxetine. Individuals with high baseline IL-10 levels tend to have late onset major depressive disorder, which is associated with a better prognosis. Note that there was no association between IL-10 and responders in the venlafaxine study. This suggests that there are predictive biomarkers specific for each class of antidepressants. And finally, the other conclusions and their justifications support the third conclusion.
While the study itself had some very interesting findings, there were a few limitations. One such limitation was a lack of control for compounds such as cigarette smoking, BMI, ethnicity of participants, comorbid diseases, or socioeconomic status, compounds which can all impact the levels of the biomarkers. Another limitation was the susceptibility of the biomarkers to concomitant inflammatory diseases and regular anti-inflammatory treatments such as ibuprofen, which could have affected the levels of the biomarkers and could have skewed the results. Another was the strict inclusion criteria, which may exclude some major depression disorder patients, lowering the translatability of the study itself. A final limitation was that the results were not adjusted for multiple testing. This would possibly cause false positives in the study itself. One interesting finding of the study was that within the SSRI treatment group, an increase in biomarkers was related to a decrease in depression symptomology. This is interesting because this goes against literature and the baseline findings of the study itself that links high levels of inflammatory biomarkers such as interleukin-6 with high depressive symptomology. This is what we believe should be explored in future studies. One possible study that we propose is a mouse study that would look at the difference between increased inflammatory biomarkers and SSRI-induced biomarker elevation on depression symptomology. A possible finding that would suggest an unknown interaction between SSRI and biomarkers and MDD that lead to the elevated biomarkers would be that there is only a decrease in depression symptomology for the SSRI group. This would suggest that there is further need for investigation of exactly how SSRIs treat depression. Here are our references.